Hi, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha. I'm a nurse here at UWorld. I know we're in crunch time for a lot of y'all taking your NCLEX in the January, February era. So we're trying to hit some big, heavily requested topics, and one of those is pediatric topics. So today we're going to look at a couple different pediatric complications or conditions. We're going to cover RSV or respiratory syncytial virus, strep throat, and head lice to cap it off. So a couple of housekeeping things. We do take into account the topics that you all want to see. This pediatric topics was a recommendations from one of our viewers. So keep letting us know the topics you want to see us present. We definitely take those into account. Let us know how we can best help you. There will be questions throughout today's video, one sprinkled in throughout, just to challenge you guys along the way, as well as our NCLEX style questions at the end. So make sure you're staying tuned for those. Follow us at UWorld Nursing on your preferred social channel. We just hit 50,000 followers on our TikTok and our YouTube page. Thank you guys so much for that. It is because of you that we got there. We are really excited about that milestone, and we're aiming for 100,000 through the end of 2025. So help us get there. If you haven't liked, subscribed, shared, followed, go ahead and do that today. As always, drop your comments and your questions in the chat. We have the fabulous Nurse Jackie standing by, moderating, ready to answer all of your questions, your comments, and of course, your answers to today's questions. So let's get the chat started by letting us know where everyone's joining from, who is from the US, who is from an international viewer. If anyone's in a really cool place, let us know. We're just in chilly Dallas right now. Alrighty, so again, the agenda slide, we're covering 3 topics: RSV, strep throat, and head lice. So let's go ahead and jump into RSV. So we're going to start with RSV being respiratory syncytial virus. Another name for this is bronchiolitis. And it's an extremely common viral infection that affects a lot of pediatric clients throughout cold and flu season. So if you were to go into a pediatric ER in the winter months, you're going to see a lot of RSV. So what happens in RSV? It's a very catchy virus. So what we mean by this is it's spread by respiratory droplets via direct contact, like a child to child, or indirect contact, like through toys. So if a child was to be infected with this virus, play with the toy, leave it there, another kid comes along and picks this up, they can also catch it through indirect contact. So when you think of droplets, think of sneezing and coughing is how it's being spread. So in our lungs, we have these small tubes called bronchioles where air passes, and bronchioles are going to be the very smallest branches of our airway. In RSV, these bronchioles are what get inflamed, and we have mucus secretions increase. So that inflammation and increased mucus secretions are really the 2 main complications of RSV that cause all of these manifestations. Essentially, these 2 things combined make it harder to breathe. So when we think big picture, RSV, it's all in the name. We know it's respiratory. So big picture, we're going to have a respiratory distress, and it's viral. So a lot of our treatment here, our interventions are going to be supportive care. Before we dive into our risk factors, one quick note is that RSV is diagnosed using a nasopharyngeal swab. So think of the same as those original COVID tests. They're really unpleasant even for an adult client, but as you can imagine, they're especially unpleasant for a pediatric client. Alrighty, next up is risk factors. And again, feel free to screenshot this RSV table. All of these visuals that we give you guys, you're free to screenshot, take them home with you, save them for your future studies. But again, RSV is a virus. It affects our youngest populations, and it can also, on the flip side, affect our oldest populations. So think infants about 6 months or younger, and also think elderly clients. They're at a very high risk for not only contracting RSV, but they're also at a high risk for complications resulting from it. So another people that we can think about for risk factors are immunocompromised, like people on chemotherapy or people who are on immunosuppressant medications. Examples of this may be someone who had a transplant, an organ transplant, a skin transplant, and we're trying to prevent graft versus host disease, so they're on an immune suppressing medication. Clients with underlying pulmonary conditions will also be at an increased risk for developing RSV. So our COPD clients, our cystic fibrosis clients, and a big one in our kiddos is that asthma. The lungs in these conditions are already compromised in different ways. So this worsening inflammation, the increased exudate and secretions are only going to lead to bigger problems for these clients. And our last risk factor to drive home are these pediatric clients that are exposed to secondhand smoke. So we're hoping that a pediatric child is not already firsthand smoking or smoking cigarettes, but we're hoping that if they are exposed to secondhand smoke, this is an increased risk for RSV. Again, that inhalation of the smoke causes inflammation in the lungs. It's similar to what we would see in clients with an existing condition that we just talked about. It just is going to lead to further and worsening inflammation of the lungs, and these pediatric clients with secondhand smoke exposure are more likely to suffer from complications from RSV. Alrighty, let's jump into clinical features. So the severity of the clinical features that are seen in RSV are really going to vary. We can have our moderate cases, our mild, and of course our severe. So the onset, again, of RSV may vary, but the symptoms typically peak around day 5, with that day 3 to 5 really being the toughest time. So symptoms can be as mild as a runny nose, cough, sneezing, fever, a sore itchy throat, but over time these are going to worsen, and we really start to worry about the A and the B of our ABCs. Remember, ABCs are airway, breathing, circulation. They're our top priorities for nursing intervention, but A and B is airway and breathing, and RSV affects those two things more than anything. So we can differentiate RSV from a cold because in a common cold, a lot of the symptoms really affect the head, you're stuffy, you're congested, but with RSV, the majority of the manifestations present and originate via the lungs. Alrighty, so before we pull up the next image for you guys, I want you to tell me in the chat, what do you think pediatric clients look like when they're in respiratory distress? All right, so pediatric clients in respiratory distress, what are some things we're going to see here? Let us know in the chat. And we have a very chatty chat, which I love to see. I love to see you guys participating. We're so happy to have you here. And I see a lot of viewers from Kenya and Ghana and Spain. I don't see any answers to my question yet, so I'm going to give you a few more seconds. I see Portia says restless. This is very true. Way to go, Portia. All right, I'll give you a few more seconds. Fatigue, irritable, dyspnea. Okay, so way to go, you guys. Let's go over this in a little bit more depth. I'm going to pull up the labored breathing image. It shows a pediatric client suffering from some respiratory distress here. And it's going to look like we're going to see signs, of course, of respiratory distress, signs of hypoxia. So starting out with respiratory distress, a pediatric client, we're going to be able to auscultate adventitious lung sounds. So think about things like wheezes and crackles. Wheezes happen when air has a narrower path to travel. It almost sounds like a whistle upon auscultation, and crackles happen from that resulting fluid, so kind of like popping, bubbles popping like sounds. These sounds are due to the inflammation of the airway is what results in the wheezing because of the narrowing, and the increased secretions are what contribute to the crackle sounds. We're going to see a use of the accessory muscles to breathe. This is really well illustrated in this visual. Essentially, the body is engaging muscles that aren't typically used in the breathing process because we need to recruit help. The lungs are having trouble getting enough air. We need to use accessory muscles to help get us there. You may hear sounds like grunting, especially in our young clients and our infant clients, and you're going to note retractions. Retractions are a big sign of respiratory distress in our pediatric clients. You can see them around the ribs, around the neck. Retractions in the ribs would be called intercostal retractions. Below the ribs, right at the top of the abdomen where that rib cage ends, are called subcostal retractions. And then in our neck, we can have those suprasternal retractions. And this is something you're really going to see in pediatric clients in respiratory distress. Other things you'll see is nasal flaring. We're also going to have tachypnea, or an increased respiratory rate. I see someone saying dyspnea. This is not quite right. We're more likely going to see tachypnea to compensate for the inflammation in the airway. These kids are just trying to get as much oxygen as they can. And of course, we will see hypoxia with respiratory distress, which is just O2 sat less than that 90%. Alrighty, but I did see a lot of retractions. I saw a lot of nasal flaring. Way to go, you guys. Restless agitation. You guys got it. And I see one use of accessory muscles from Kazim. So way to go, you guys. So we're also going to focus on our nursing intervention. So again, we're really going to focus on these interventions for these moderate to severe clients. But first things first, we want to prevent the spread of infection. So we need to enact our droplet precautions. So tell me in the chat, what are our droplet precautions? These ones are always tricky for me in nursing school, learning the difference between contact, droplet, and then of course airborne. But our droplet precaution for RSV, what is this going to look like? What are you, as the nurse, put yourself in this scenario? What are you going to be covering up with, putting on? Let us know what our droplet precautions are. Alrighty, so droplet precaution for droplet infection are going to include the gown, the gloves, and the mask. We are not going to be using an N95 respirator. That's for airborne. We just need that surgical mask. Alrighty, so now that we're dressed and ready for care, we want to focus on supportive care. Again, this is a virus, so we're going to include things like administering our IV fluids to keep this client hydrated. Also, IV fluids help to thin secretions, making them easier to expectorate and get out of your system. We're going to monitor their oxygen. Our goal is to keep them above 90%. We also want to consider applying warm and humidified oxygen to help further open and relax that airway, to kind of work against the inflammation and to help break up the secretions that we see, again, making them easier to cough up or expectorate. These clients will also most likely have a very high fever, which can be dangerous. So we want to give the appropriate antipyretics like an acetaminophen or a Tylenol. We don't give aspirin to pediatric clients with viral illnesses. Why is that? I'm going to ask you guys another question in the chat. So why would we not give aspirin to a pediatric client with a viral illness? This is a tricky question. It definitely challenges you guys. But what's the danger here? What can these clients be at risk for developing if we give a pediatric client an aspirin when they have a viral illness? I'll give you a few seconds to answer. And I'll give you a little hint. It's a syndrome, and I see you all already got it right. I think my chat's just a little bit lagging today, but Ray's syndrome is what we're worried about. I see that, let's see, Stella got it right, Liv got it right. Way to go, you guys. So yeah, we're really worried about Ray's syndrome. That's why we don't give aspirin to a pediatric client who has a viral illness. This is really common. Ray's syndrome, we see it develop in pediatric clients around age 4 to 12 are really the biggest risk for it. But this is why we would use an acetaminophen rather than an aspirin. So we want to ensure also part of our supportive care is that we're positioning these clients in a position that promotes airway clearance. So for pediatric clients, think 30 to 40 degree elevation. That neck should be slightly extended, nothing smushed up. We want to make sure we're elongating that airway, especially for babies that maybe don't have those neck muscles to be able to adjust themselves. We want to make sure we're positioning them in an appropriate way. We are also going to be frequently suctioning these clients. Pediatric clients have less matured lungs, they have weaker lungs. They're not always able to have that same cough reflex that a healthy adult would. So they're not able to properly expectorate and cough up these secretions. So chances are these pediatric clients are not going to like the suctioning. So for a small infant client, consider a swaddle that holds down their arms so we're able to suction freely. And for an older toddler client, you want to cue them in on what's going to happen, show them your equipment, let them look at the suction, and then make sure they know what's going on before you suction, just to help them maybe be a little bit more amenable to it. Alrighty, monitoring intake and output, so important. We want to make sure the client isn't getting dehydrated, which we know can happen with these illnesses, especially if they have a fever. They can be sweating, they may not have much of an appetite, they may not be drinking as much. They could really risk being dehydrated here as a complication of the RSV. And in our littlest clients and our infants, we're going to monitor intake and output via weighing and counting their diapers, their dirty and soiled diapers. Alrighty, monitoring activity level and monitoring for signs of decompensation. Someone mentioned this earlier and you are absolutely spot on, but kids are so resilient until they're not. So if we see a pediatric client really becoming listless, restless, maybe they're agitated, or maybe they just are completely fatigued, this is a sign that the client is decompensating, and we would want to be vigilant for this. Our last intervention here is to monitor for any secondary infections, things like pneumonia, acute otitis media, or an ear infection. Whenever we have that stagnant increased secretion, those are just breeding grounds for bacteria, and we can have these opportunistic secondary infections that make their way in, which is the last thing that these RSV clients need. Alrighty, way to go, you guys. That sums up our first part of today's content. Now we're going to move into strep throat or streptococcal pharyngitis. So strep throat, we're shifting gears. RSV was a virus. Strep throat is a bacterial infection. It's a very common pediatric condition, and it's a common adult condition. It's caused by that Streptococcus pyogenes, which is a group A beta hemolytic streptococcus bacteria. My goodness. It's diagnosed by a throat culture or a rapid strep antigen test. test. We always want to perform that detection test just to be sure, but there's several distinct symptoms that are really going to key you into, oh, this could be strep throat, which leads us to our next section, our clinical features. Again, go ahead, screenshot this strep throat table. Any of these visuals that we put out for you, you are welcome to take along with you. So what does strep throat look like? These clinical features are going to be things like an abrupt onset of a really sore, irritated throat. This may look like redness that can be visualized in the back of the throat, swollen tonsils with the potential for exudates. We can have that palate petechiae, or that pinpoint red-purple spots on the palate. Clients will have fever and can have anterior cervical lymphadenopathy, which again is just those swollen lymph nodes. We really see them right in the front of the neck and slightly to the side. A really important thing is that pediatric clients a lot of times will present a little bit differently than adult counterparts. So we can actually see GI upset, stomach upset from strep throat in our pediatric clients because some of that strep bacteria meanders its way down to our GI system, and we can actually see kids coming in with an upset stomach with GI upset as a sign and symptom of strep throat. Alrighty, so now let's move into our clinical features really set us up well to lead into the complications that can result from strep throat. So this is unique to strep throat in being untreated strep throat can lead to some really dangerous complications. This is a little bit different from the RSV section. So we're going to look at a few of them. First, I'm going to pull up an image of our peritonsillar abscess. This is just one of our unpleasant potential complications we can see from strep throat. But a peritonsillar abscess is just an abscess in the tonsil, exactly what it sounds like. It can be emergent because if it gets large enough, it can actually obstruct the airway. Our pediatric clients already have small airways, so any obstruction is really a cause for concern. These peritonsillar abscesses will present with fever, with chills. They can lead to some really, really terrible pain. And clients, because of this pain, may not be able to really eat enough, may not be drinking enough, so they can come in very dehydrated. This can also present as a muffled voice from just the size of that abscess. And the swelling of the tonsil can even deviate that uvula. So if you remember back to your nerve test and your health assessment class in nursing school, the uvula should be midline. Anything that swells the tonsil, which are on the sides of the back of the throat, can shift that and deviate it from the midline. Another sign of a peritonsillar abscess. Alrighty, moving on. I see someone saying this is a little fast. I'll try and slow down, but we have a lot of stuff to cover today. So next we're going to move on to rheumatic fever, another sign or a potential complication of untreated strep. So rheumatic fever can take 2 to 3 weeks to surface, so it can be a little delayed. Again, this happens in untreated strep throat, so our clients who are not seeking medical attention or our clients who are not taking or finishing their antibiotics. So what happens is antibodies against strep bacteria develop, and they actually work autoimmune. They attack the healthy tissues of our bodies. So our heart, our joints, and our kidneys can be attacked via this rheumatic fever. So really dangerous here. What we're most worried about is that pericarditis, which is the inflammation around the heart. We can also see joint pain because we know it attacks the tissues of our joints, or even chorea, which is involuntary muscle movements. Alrighty, chorea is pretty rare too, just so you're aware. Next is acute post-streptococcal glomerular nephritis. Huge word, long one there. But again, this is another potential complication of untreated strep throat. So what we're going to see here is the invasion of the strep bacteria all the way down into the kidneys. It's going to manifest many times as peripheral edema from that impaired kidney function. It's kind of the same pathology here as an acute kidney injury or an AKI. Signs and symptoms will be hypertension and Coca-Cola colored urine. So this colored urine is essentially a color variation of hematuria being blood in the urine. So instead of that frank blood, it's going to be dark, but it signifies kidney injury, and it is a sign of acute post-streptococcal glomerular nephritis. If a client experiences this, they should immediately follow up with their provider. And last but not least is going to be scarlet fever. So this is kind of an old-timey, I feel like this takes me back to like Little House on the Prairie days. And if any of you remember this, I think Mary in Little House on the Prairie actually gets scarlet fever. But it's going to present as sandpaper-like rash, so really red, rough, irritated, and strawberry tongue. And strawberry tongue is that beefy red papules that look like strawberries. Again, these are all from untreated strep throats, so people that are not taking or finishing those antibiotics. But again, those are our three main complications, or four, sorry: peritonsillar abscess, rheumatic fever, acute post-streptococcal glomerular nephritis, and scarlet fever. Alrighty, so some major complications that can happen. Our last part of strep throat are going to be nursing interventions. So of course, our biggest thing for a bacterial infection are always going to be our antibiotics. I'm going to ask a question out to the chat again, really trying to keep you guys engaged today. But what is our main antibiotic we're going to see prescribed for strep throat? Barring any allergies, what's the most common antibiotic that we would see prescribed to treat strep throat? Alrighty. I'm going to let you guys know. Go ahead and drop that in the chat. Let me see. I'll give you guys some time. I think my chat is a little bit delayed, so I'm just going to give you a few seconds, but you guys got it. Liv, penicillin, you are absolutely right. I see some PCN, so you guys are spot on. Way to go. Penicillin is going to be kind of our first line for strep throat. Of course, we do have a lot of clients that have penicillin allergies. In that case, a lot of times we give like a cephalexin, which is a cephalosporin antibiotic. We also need to offer supportive medications, so things like antipyretics to reduce fever and analgesics to help with the pain, especially if they have maybe an abscess or a really sore throat. We're going to teach the client about the need to consume soft foods, cool liquids, just to not irritate. And other comfort measures can include adding a humidifier to the client's room. That humidified air is much more gentle on the airway, and gargling with salt water, warm salt water, can also help to reduce some of that pain, ease some of that inflammation as well. And lastly, something really important to hit on is to prevent reinfection. So we're going to do some important teaching. Pediatric clients most likely are going to have a caregiver, a parent along with them. And we need to teach them that the client is considered contagious until 24 hours after initiating antibiotic therapy. So we're keeping them home, ideally for post 24 hours, really after their fever has resolved as well. So this is a good rule of thumb for when to send them back to school. And we also want to tell the caregiver that after about 24 hours to 48 hours on antibiotic therapy, we want to dispose of their toothbrush and use another one to prevent reinfection. If we're helping you get over a strep throat, the last thing we want to do is reinfect these pediatric clients and have them just start from square one all over again. Alrighty, so we are on our last section of the day, and that is lice. Today's is a little bit long, so thank you for bearing with me. But again, I feel like pediatric content is so important. Pediatric clients always present a little differently, and it's really important on your NCLEX to be able to identify how they present differently. So lastly is our easiest topic of the day, so you made it through the hard stuff. We're going to move on to head lice or pediculosis cupitis. So this is kind of like a rite of passage for nurses. I feel like in your first year of nursing, everyone gets one, maybe scabies, or maybe one lice clients. But it is a very, very contagious parasitic infection. It's spread through contact, so either direct contact, like a kid to a kid, or indirect, meaning a kid can use a hairbrush, put it down, another kid comes along, picks it up and uses it, and now they're infected with lice as well. So let's walk through how this happens and why it's so contagious. So a big thing here is that these female lice will lay eggs called nits on the hair shaft really close to the scalp, and over the course of those 2 weeks, those eggs that they lay hatch and they develop over 2 weeks into adult lice of their own, and then they go on to lay eggs. So the cycle continues and continues. So it develops very quickly. As they lay more eggs and the process continues, the infection worsens until it's treated. So without treatment, this multiplies very quickly. Lice will most commonly be seen in our school-age children or children in child care facilities like a daycare or a preschool or things like that, where kids are in really close contact with one another. So clinical features here, pretty straightforward. It's mostly around itching and pruritus. They're going to have really itchy scalps. So an important thing here is to make sure the fingernails are short so we're not itching to the point of breaking the skin, because this is going to be an ability for a secondary or a subsequent infection to get in. Nits a lot of times will be seen at the nape of the neck, behind the ear. We can see them on the scalp line, and they're just really light colored specks that'll be visible on the hair shaft. So pretty much itchy scalp, visible lice, main manifestations of head lice. So our nursing interventions. So the first thing we want to do is protect ourselves. In a healthcare facility, we want to cover up on ourselves before we go into this room to treat this client with lice. So what you're going to want to do is put on a gown and gloves at the very minimum. But in reality, if you have long hair, you want to tie it up, and you always want to put a surgical cap on. If it was me, I would probably put a couple of surgical caps on. And next, we're going to instruct the client or assist the client in applying applying a pediculicide shampoo, which is about like a 1% permethrin to the scalp, we need to tell the client or the caregiver to leave it on for 10 minutes after it's been applied, and then we wash the hair in the sink so there's not a likelihood of it infecting other hairy areas of the body. We want to wash the hair with warm water and not hot water, which is a little bit different from the rest of our instructions. So why is this? We don't want to increase vasodilation with that really, really hot water when we wash the hair. We want to do warm water to decrease vasodilation so we don't have a systemic absorption of this medicine, of this permethrin. Alrighty, after shampooing, they should run their extra fine tooth comb through the hair to remove any additional nits, and repeat this treatment in 7 to 10 days after the first time to treat any newly hatched lice that the first treatment did not eradicate. The caregiver should soak any infected hairbrushes, any prior used hairbrushes, in hot water for 10 minutes. And also, lice travels very fast in a household where we're all in close contact. So other members of the household, other children, and the caregiver themselves need to be checked for lice as well. In terms of the house, we want to make sure we're vacuuming carpets. Anything that can be washed, we want to wash in hot water and dry on our hottest setting, just to kill off those lice. And any non-washable items, maybe they're too big, maybe they don't go in a washing machine, we want to seal it in a bag and leave it for 2 weeks so we can suffocate any existing lice. Again, I brushed on this earlier, but making sure the client has trimmed nails so they're not breaking or excoriating the skin of the scalp. And we also want to hit on therapeutic communication. So especially in a pediatric client, having lice, having this infection, this infestation may make them feel embarrassed or isolated. So it's really pertinent to make sure we are communicating therapeutically and non-judgmentally. Alrighty, way to go, you guys. That was so much information, but you all did awesome. I think it was almost 30 minutes of just me straight talking. So now we're gonna break it up a little bit by heading to our NCLEX style questions. You've done so well. I'm sure you'll do great on these as well. But question number 1 is that the nurse is caring for an infant with respiratory syncytial virus, RSV. Which of the following findings would the nurse expect to observe? Select all that apply. Our options are fever, tachypnea, poor feeding, sunken fontanelles, and tearless crying. So let us know. So you all know uworldnursing.com is a home base for all of our nursing social efforts. If you have any questions about UWorld, if you want to learn more, you want to see what topics we're doing, go ahead and check out uworldnursing.com. It gives you a great 3-week synopsis of all the topics we're going to present, so you can see what you want to tune in for, what you can't make, and you can also plug in your name and your email to get an email straight to your inbox at the beginning of every week so you know what's going on and you have direct links to click to get there. So make it easy on yourself and go ahead and subscribe at uworldnursing.com. Alrighty, I see some answers coming in. Let's see. Most of you are getting 1 and 2, which were indeed correct, but I see a little bit 3, 4, and 5. It looks like you're kind of all over the board. So our correct options were 1, 2, and 3. So fever, tachypnea, and poor feeding. Why was this? So remember, we're thinking in the realm of RSV, that virus. So fever, this is true. We know that these RSV pediatric clients especially are really susceptible to high fevers, and we want to give an age-appropriate antipyretic, aka not an aspirin. So fever we know can be a potential finding the nurse would expect to observe. Tachypnea, or an increased rate of breathing, completely normal expectation. An RSV client would increase their rate of breathing. And lastly, poor feeding. So if you can't breathe properly, you're probably not going to want to eat. So these clients will have decreased appetites, poor feeding. This is again an expected finding of RSV. Why was it not 4 and 5? So sunken fontanelles are a sign of dehydration. And while dehydration can result from RSV, it's not a direct finding. It's kind of a complication down the line. That's why we didn't select sunken fontanelles. Alrighty, moving on to question number 2. The nurses taught a client with newly diagnosed streptococcal pharyngitis. Which of the following statements by the client would indicate a correct understanding of the teaching? Select all that apply. 1 is I plan to place a humidifier in my bedroom. 2 is I should contact the clinic if my urine color changes. 3, I will receive an antiviral medication. 4, drinking cool citrus juices will be soothing to my throat. And 5, gargling with a warm saltwater mixture will alleviate my pain. Alrighty, keep those answers coming. I think I have all select all that apply for you guys today, so I am definitely challenging you, but I know you can do it. We also now offer a question of the week feature. So we've been doing question of the day for a couple of years now, and we really find that people respond to them. They really like seeing them. We now offer a question of the week. You can sign up for it via that uworldnursing.com page that I just talked about. But go ahead, check that out, subscribe to the question of the week, and you'll get a question straight to your inbox every week. Again, we have so many of these free resources that we're offering to our students, and I want to make sure that you guys take advantage of them, use them to help you get where you need to be with that NCLEX. Okie doke, and I see some answers coming in. All right, I see a bit more of a mixture, so maybe we need to spend a little bit more time on this one, and that's totally fine. But our correct options were 1, 2, and 5. So why was this? We've switched gears. We were talking about RSV. Now we're to strep throat. So this is a bacterial infection. Keep that in mind. Option 1, the humidifier in the bedroom. This humidifier helps to humidify the air, exactly what we think. That helps to soothe the throat, and it helps to thin and break up any secretions too, making them easier to expectorate. So we would want to do this just for client comfort. Option 2, contact the clinic if my urine color changes. Remember that we have a risk for a complication of strep throat of that acute post-streptococcal glomerulonephritis, which attacks our kidneys, and we can see urine color changes from this, specifically that like Coca-Cola colored urine. So any of these urine color changes really need to be promptly reported to the provider, to the healthcare team, or to the clinic in this case. Lastly, option 5, gargling with that warm salt water. This will help to soothe the throat, reduce pain, reduce inflammation. It indeed is something that we would want to do. So 1, 2, and 5 were our correct options. 3 and 4 were incorrect. So remember, it's a bacterial infection. We don't want to give an antiviral for a bacterial infection. That will not help out the situation. Option 4. Citrus juices are really acidic. This will sting and burn. If you've ever had like an orange juice when you have a sore throat, it's painful. So this is not going to increase client comfort. It's not a supportive intervention. Again, 1, 2, and 5 were our correct options. And lastly, question 3. So moving on to our final question, our head lice question, another select all that apply. The nurse is teaching the parents of school-age children about the treatment of pediculosis capitis, or head lice. Which of the following information should the nurse include? Select all that apply. So option 1 is wash your child's bed linens in cold water. Option 2 is to keep your child's fingernails trimmed short. 3, remove nits from your child's head using a fine tooth comb. 4, treat all your household pets with a pediculicide. And 5, seal non-washable items in a plastic bag for 10 to 14 days. Alrighty, drop those answers. Way to go, you guys. And when does everyone graduate? Let me know when you plan to graduate from nursing school. I bet we have a bunch of spring grads coming up this April, May. That's so exciting. Congratulations. But if anyone's graduating maybe the end of summer, December, if you just graduated this past December and you're in your nitty-gritty process of studying for that NCLEX, let us know. But we're always so curious as to where everyone lies in their nursing journey. So let us know if you're a May graduate, a spring graduate, a summer graduate, or a soon-to-be winter graduate. We are always curious to find out. Jada graduates in July 2025. Congratulations, that's so exciting. And then Marion graduated in December, this past December, so way to go. Well done, you guys. I see lots of answers coming in, and let's see what you guys are thinking. All right, so our correct options here are going to be 2, 3, and 5. So I see mostly 2, 3s, and 5. It looks like a couple of you may have added the 4 in. But let's walk through this. So we want to make sure we're keeping short fingernails as an option too. Again, the main manifestation we're going to see from head lice is that itchiness, that pharyngitis. And if you have long nails, we can break the skin of the scalp when we're scratching. So keep those fingernails trimmed short. Option 3, remove nits from your child's head using a fine tooth comb. The finer the better. We really want to help get out some of those nits really at the base of the hair shaft. This prevents worsening infection. And lastly, 5, seal non-washable items in a plastic bag. This is for anything that cannot go in our washer dryer. We seal it away ideally for 2 weeks or 14 days, and this suffocates the existing lice. So when we break it back out, when it's opened back up, all these lice are now dead. Options 1 and 4 were incorrect. So remember, we're not washing the bed linens in cold water. We're washing it in hot water. And lastly, 4, treat your household pets with a pediculicide. So interesting enough, pets cannot get head lice. It requires a human host. However, humans, although they can get bitten by fleas, humans cannot retract fleas or contract fleas. They can't live on a human host. So we're not worried about lice for our pets, but we are worried about fleas. So again, we would not treat them with this lice medicine. Alrighty, great job, you guys. Way to go. We're going to switch to our QBank slide now. It's just a great little refresher for anyone that already has our product. This way you can see how to get more pediatric questions. Go to the child health subject, and the system you can choose integumentary if you want questions maybe more about lice. If you want to do more respiratory, that'll give you our RSV. And our infection control section 2 is also a great thing if you really want to drive home those precautions, airborne, droplet, all that good stuff. So again, for all of our UWorld users, here is just a quick little bookmark shortcut for how to get more questions like the ones you saw in today's lecture. In closing, thank you so much for staying tuned. This was a lot today. This ran long. We're at 12:36, a little bit longer than I normally go. Thank you for hanging in there. Pediatric clients often present differently, so it's important to understand how these pediatric manifestations can differ from adult ones. But you guys did such a great job. Way to go. We're going to be back at 2 and 3 p.m. tomorrow with endocrine questions, so make sure you hop in and join for that. Thank you so much for hanging in there today. Way to go, and I'll see you soon.